First, we will tackle the question, what is goal attainment scaling? Throughout the presentation and the course, we will be referring to goal attainment scaling by its acronym GAS. We will interchangeably use GAS and goal attainment scaling. So what is goal attainment scaling? It's a technique used to evaluate functional goal attainment. It can help document how a client progresses over time. A goal is made for a client, then the clinician makes 2 objectives that are more than anticipated and 2 that are less than anticipated. The objectives are labeled with -2, most unfavorable treatment outcome, -1, less than expected success, 0, expected level of success, which would be your typical actual goal, 1, more than expected success, and 2, best anticipated success. These classifications are denoted on the side. They are referred to as the process of scaling goals. The clinician can combine all scores from multiple goals to get an overall goal attainment score. This process will be talked about later in the course. GAS was developed by Kirasuk and Sherman in 1968 because they wanted a better way to measure change with their clients. They worked in the mental health population. They found using GAS it was a better way to document change and could help them in constructing their abstract goals. When this article was published in 1968, Kirasuk and Sherman advised that goals be weighted. More important goals with more weight. But later, in 1994, they advised that with new statistical methods, the weighting system was no longer needed. This was in their new book. In 1979, Citronbaum and colleagues conducted a literature review in GAS. At this time, GAS was considered the most popular outcome evaluation technique in the human sciences. It wasn't until 1983 when Clark and Caudry introduced GAS to the rehabilitation world. Later, in 1994, the creators of GAS wrote an updated book of the method. This book further illustrates how goal attainment scaling can be used with a variety of professionals. As you can see, researchers have defined what the -2 to +2 objectives mean. This shows there is not one uniform way to scale goals, according to the literature. The column farthest to the right is what the creators of GAS intended each level to be. For purposes of this course, we will use King's scaling method with baseline equaling -2. This is the set of goals that are in the second column. This will make goal setting more clear. This slide gives examples of how Kirasuk and Sherman scaled goals. In this example, there are 5 different goals that they are using for one client. They have scaled each goal accordingly, -2 to +2. The person selected was in the mental health population. In this example that Kirasuk and Sherman pick, you can see that there is a weight placed on these goals. But as was explained earlier, this is no longer needed or advised. Just take a look at these goals, and you can pause the video if needed and make it full screen to take a closer look at the goals. And I want you to notice how the goals are scaled and how there is an equal space in between these scales. Later in the course, we will review how to apply this scaling method to different populations. There have been many populations that have used GAS in their practice to document change. Some of these populations include community-based mental health promotion, cognitive rehabilitation, acquired brain injury, health promotion, early intervention, the geriatric population, physical therapy, occupational therapy, and speech therapy. Carol Conway will be providing her feedback throughout the course. She is an OT in the schools who would love to start utilizing GAS in her practice. She has taught a guest lecture about GAS in a course at Cleveland State University's occupational therapy program. I'll let her introduce herself.
Hi, I'm Carol Conway. I'm a pediatric occupational therapist who works in the school district in Hudson City Schools. I have been an occupational therapist for 33 years. I've been in the schools for the past 24 years, and prior to that, I worked in outpatient rehab in pediatrics, and I have a master's degree in psychology.
One question we asked Carol is if she saw GAS being useful for all the population she worked with. This is her response.
I think I could really use it with all my clients in school-based practice because it correlates so closely to an IEP objective, and the IEP objective, of course, is legislative, and I need to do it that way. But I need to measure progress in a way that has a numerical value, and so I do feel like I could use this for all my students.